Assalamu alaikum. I am Dr. Noor and this lecture is about antidiarrheal drugs. The objectives of this lecture is to classify commonly used antidiarrheal drugs, to explain the mechanism of action and common adverse effects of each group, and then to manage a patient with diarrhea accordingly. So, what is diarrhea? Is it one liquid stool each day? Is it several soft, semi-formed stools each day? Is it frequent watery stools throughout the day and night? Or is it stools with water content from 60 to 90%? An abnormal increase in frequency and liquidity of stools is known as diarrhea. The causes of diarrhea include bacterial and viral infections, food intolerance, parasitic infections, reactions to medicines, intestinal diseases, functional bowel disorders, post-surgical procedures, and unknown factors. Bacterial infections are mainly caused by the contaminated food and water consumption, and the organisms commonly causing diarrhea are Campylobacter, Salmonella species, Shigella, and Escherichia coli. Viruses that cause diarrhea include Norvalvirus, cytomegalovirus, herpes simplex virus, viral hepatitis, and rotavirus, which is a common cause of acute childhood diarrhea. Food intolerance can be a cause of diarrhea. For example, in cases of lactose intolerance, when a person has symptoms like abdominal pain, bloating, diarrhea, gas, and nausea due to a decreased ability to digest lactose, a sugar found in dairy products. Other food allergies can also cause diarrhea. Parasites causing diarrhea are Giardia lamblia, Entamoeba histolytica, and Cryptosporidium. Some medicines can also cause diarrhea, for example, antibiotics and magnesium-containing antacids. Intestinal diseases like celiac disease and inflammatory bowel disease, also known as IBD, which includes ulcerative colitis and Crohn's disease, are all causes of diarrhea. Escherichia coli, Entamoeba histolytica, Giardia lamblia, and cholera can cause diarrhea in travelers. In this slide, symptoms of different causes of diarrhea are given. For example, in viral gastroenteritis, which is also known as stomach flu, nausea, vomiting, watery diarrhea, fever, and aches usually last from 1 to 3 days. Whereas in bacterial infections, there is diarrhea, fever, chills, sometimes blood or mucus in the stools, but vomiting is less common. In cases of food intolerance, there is bloating, gas, cramps, loose stools hours after eating dairy products or other offending foods, but there are no other signs of illness or infections like fever. In emotional distress, there is cramping and loose stools, especially predictable during times of stress. There are two types of diarrhea: acute, also known as short term, which lasts for less than 4 weeks, and chronic, which is long term and lasts for more than a month. In acute diarrhea, bacterial, viral, and parasitic infections are the main causes, whereas in chronic diarrhea, irritable bowel syndrome, inflammatory bowel disease, lactose malabsorption, and chronic laxative use are the common causes. Diagnosis can be made by history, examination, stool culture, electrolytes, fasting tests, sigmoidoscopy, and colonoscopy. Now, let's review the pathophysiology of osmotic diarrhea, secretory diarrhea, rapid transit of stool, and exudative diarrhea. Increased luminal osmolality is the cause of osmotic diarrhea, which is when non-absorbable osmotically active solutes are present in intestine and they promote retention of fluid, thus stimulating peristalsis. Examples include magnesium antacids. As fluid follows sodium chloride into the intestine, increased chloride secretion results in secretory diarrhea, for example, in cases of bacterial toxins and laxative abuse. Conditions like diabetic neuropathy, stress, and irritable bowel syndrome causes increased intestinal motility that results in decreased time for fluid reabsorption. Inflammation of intestinal mucosa, such as in cases of ulcerative colitis, results in exudative diarrhea. How to approach a patient with diarrhea? Our main focus should be on the maintenance of fluid and electrolyte balance and Use of anti-infective as well as anti-diarrheal agents. ORS is given for the maintenance of fluid and electrolyte balance. Glucose, sodium chloride, potassium chloride, and trisodium citrate are the components of ORS. Anti-infective agents, for example antibiotics, should only be given in cases when culture is positive, so that the resistance to antibiotics can be avoided. Anti-diarrheal agents include anti-motility drugs and adsorbents. Now, anti-motility agents include opioids and antimuscarinic drugs. Opioids, for example codeine, diphenoxylate, loperamide, which is also known as Imodium, and synthetic drugs that are chemically related to narcotic meperidine decrease intestinal motility, for example in cases of traveler's diarrhea. Their mechanism of action is the inhibition of acetylcholine release through presynaptic opioid receptors in the enteric nervous system. They are used in severe or prolonged cases of diarrhea that last for more than 2 to 3 days to prevent severe fluid and electrolyte loss. Relatively severe diarrhea in young children and elderly adults, and chronic inflammatory diseases of bowel, that is ulcerative colitis and Crohn's disease. In ileostomies or surgical excisions of portions of the ileum, HIV/AIDS associated diarrhea, and when specific causes of diarrhea have been determined. Adverse effects include constipation, abdominal cramps, drowsiness, dizziness, and physical dependence. Contraindications include diarrhea caused by toxic material, microorganisms, and antibiotic-associated colitis. Anticholinergics decrease cramping, motility, and hypersecretion, and they are usually given in combination with opioids. As you can see that atropine is given with diphenoxylate to prevent opioid addiction. Adsorbents that absorb intestinal toxins include choline, pectin, charcoal, methyl cellulose, and bismuth salts. The classification of antidiarrheal drugs include opioids, for example loperamide, diphenoxylate, and diphenoxin. They include adsorbents, for example guanine and pectin, and miscellaneous, for example bismuth subsalicylate, octreotide, ispogol husk and methyl cellulose, atropine, DICYCLOMINE, and cholestyramine. This is another classification of antidiarrheal drugs. Opioid receptor agonists, for example meperidine analogs, include loperamide and diphenoxylate. Colloidal bismuth compounds, for example subsalicylate and citrate salts, are used in the treatment of traveler's diarrhea. Adsorbent compounds adsorb bacterial toxin and fluid, for example choline, that is naturally occurring hydrated magnesium aluminum silicate, and pectin, which is indigestible carbohydrate derived from apples. Now let's discuss about loperamide, which is an opioid. First mechanism of action is that loperamide acts principally via peripheral opioid receptors in the gastrointestinal tract, and the effects are mediated through enteric nervous system and the central nervous system. It decreases peristaltic activity of GIT and increases resting non-peristaltic tone. Also, it increases transit time in GIT and hence increases time for absorption of water content. In stomach, it decreases peristalsis and increases tone. In small intestine, resting tone is increased with periodic spasms, but amplitude of non-propulsive contractions is markedly reduced. In large intestine, propulsive peristaltic waves are diminished and tone is increased. This delays the passage of fecal matter and allows the absorption of water. Another mechanism of action is that at cellular level, presynaptically, opioids block voltage-gated calcium channels and prevent release of neurotransmitters like glutamate, acetylcholine, norepinephrine, serotonin, and substance P. In GIT, they inhibit presynaptic cholinergic nerve transmission in the submucosal and myenteric plexus. Loperamide also has anti-secretory activity against cholera toxin and some forms of E. coli toxins by acting on G1 linked receptors, thus inhibiting the release of cyclic AMP. Adverse effects of loperamide include abdominal cramps, rashes, toxic megacolon, and paralytic ileus, especially when used in high doses in children or in cases of acute infective diarrhea. Loperamide cannot cross blood-brain barrier and it has no effects on CNS. Therefore, it doesn't have any addiction potential, which is a good thing. DICYCLOMINE, which is an anticholinergic drug, inhibits muscarinic receptors in the enteric plexus and in smooth muscles of gastrointestinal tract. Motility of GIT is affected from mouth to colon. Walls of GIT are relaxed and both tone and propulsive movements are diminished. Thus, gastric emptying time is prolonged and intestinal transit time is lengthened. At cellular level, it causes the reversible surmountable blockade of cholinomimetic actions at the muscarinic receptors. It inhibits the actions such as release of IP3 and inhibition of adenylyl cyclase activity. Adverse effects of dicyclomine include dry mouth, mydriasis, tachycardia, hot and flushed skin, agitation and delirium, and at higher doses it causes blockade of all parasympathomimetic effects. Now we are going to study about irritable bowel syndrome, which is also known as IBS. IBS is an idiopathic chronic relapsing disorder characterized by abdominal discomfort such as pain, bloating and cramps, and alteration in bowel habits, that is diarrhea, constipation or both. Classification of drugs used in IBS include anticholinergics, for example dicyclomine and hyoscyamine, tricyclic antidepressants, for example amitriptyline, 5-HT3 antagonists, that is Alosetron, chloride channel activator, for example Lubiprostone, 5-HT4 agonist, that is Tegesiroid, osmotic laxative like milk of magnesia, and anti-diarrheal drug, for example Loperamide. Another classification of drugs used in IBS is 5-HT receptor blockers, for example Alosetron, chloride channel activators that are used in treatment of IBS with constipation, especially in women, including Lubiprostone, which is a prostanoic acid derivative, and linaclotide, which is guanylyl cyclase C agonist that acts on type 2 chloride channels. Anticholinergics, for example dicyclomine and hyoscyamine. Anticholinergics are used to relieve abdominal pain or discomfort, and they act as antispasmodics. Tricyclic antidepressants are used for chronic abdominal pain. In low doses, they have no effect on mood, they have anticholinergic properties, and they alter receptors for enteric neurotransmitters. Alosetron is a selective 5-HT3 antagonist. It reduces central response to visceral afferent stimulation. It inhibits colonic motility, increasing total colonic transit time. It reduces unpleasant visceral afferent sensations, for example nausea, bloating, and pain. They are used in women with diarrhea-dominant IBS not responding to conventional therapies, and their adverse effects include serious constipation, ischemic colitis, and bowel infarction. Lubiprostone is a prostanoic acid derivative, and it stimulates type 2 chloride channel in the small intestine. They are used in women with constipation-dominant IBS and in chronic cases of constipation. Contraindications include pregnancy and women of childbearing age. A clinical case scenario of acute diarrhea has been given here. A 4.5-month-old baby girl presented to hospital with a 2-day history of watery diarrhea and fever. What can be the causative organism and how will you treat the patient? Well, as you have already studied, that rotavirus is the main cause of childhood diarrheas, and the focus of our treatment should be on fluid and electrolyte balance, as there are no use of giving any antibiotic because the causative organism here is a virus. Thank you. If you have any question, you can ask me. Assessment questions are given on the next slide. Classify anti-diarrheal drugs and what is the mechanism of action of Alosetron.